So we are very lucky to be in an era where the number of agents available for the treatment of patients with relapsed refractory large B-cell lymphoma or third line or beyond has meaningfully increased. Beyond CAR T-cell treatment, over the last few years, 4 biological agents have been approved, including Polatuzumab, which is an antibody drug conjugate targeting CD79B, Loncastuximab, which is also an ADC but targeting CD19, Tafasitamab, which is a naked antibody targeting CD19, and selinexor, which is an XPO1 inhibitor. The limitation of the pivotal trials that have brought to the approval of these agents by the FDA for patients with relapsed refractory large B-cell lymphoma is that, of course, population included in the study are hyper-selected, and the efficacy and toxicity data may not replicate in real world. So it's really important to develop and look into real-world data with these agents. Polatuzumab is the one that has been approved the first in 2019. So there are currently over 15 publications, peer-reviewed publications, looking into real-world experience. When we look into single-center retrospective experience with Polatuzumab across US, Europe, and Asia, and Australia, overall, the efficacy data, as expected, don't look as good as in the pivotal phase 2. CR rates are closer to 20 to 30% as opposed to 40% or higher from the pivotal trial, and median PFS is closer to 4 to 5 months as opposed to close to 10 months in the pivotal trial. But still, Polatuzumab remains a very active agent as a bridging therapy to CAR T, and actually in a very large UK multi-center retrospective study, use of a Polatuzumab-based regimen before CAR T made it to a multivariate analysis of factors associated with likelihood of response to bridging therapy. And currently in the US, we do use a lot this agent as a bridging strategy. There's a lot of interest in trying to understand whether we could use either Tafa or Lonca also as a bridging strategy before CAR T. But the main concern is that these agents target CD19, that of course is also the same target as autologous CAR T. And so one concern is that their use before CAR T may downregulate CD19 expression. Now, we don't really have large real-world data to support their use one way or the other. And one thing, though, that we have to keep in mind is that the half-life of Loncastuximab is much shorter than Tafasitamab, and as such, the chance that there will still be therapeutic concentrations of Loncastuximab by the time lymphodepleting chemo is started for CAR T-cell infusion is much lower than for Tafasitamab. So there's definitely some interest to verify whether this could be used safely before CAR T. As for identification of agents, the standard agents as salvage treatment after CAR T, real-world data presented at ASH last year very clearly demonstrate that unfortunately either Pola, Tafa, or Lonca, selinexor is not really much prescribed currently in the US due to high toxicity and limited efficacy. None of them really have significant activity after CAR T. And in the very small proportion of patients where they work, the duration of response tends to be short, and consolidation with an allogeneic stem cell transplant is typically required. So it's very important to screen all these patients for clinical trials. One clinical trial that has shown very promising activity in the near past has been represented by trials of bispecifics. And we have to remind ourselves that one of them, ecoritamab, has been recently approved by the FDA, and most likely glofitamab will also be approved in the near future. So I believe that moving forward in real-world practice, there will be an extensive use of bispecific after CAR T, but it will be very important, of course, to generate actual real-world experience with both bispecific and making sure the trial data once again replicate similarly also in our daily experience.